Hi, my name is Jasmine Willis. I'm a fourth-year pharmacy student, and I'll be talking to you about drugs and lactation and total parenteral nutrition today. So first, we'll go over drugs and lactation. So some benefits of breastfeeding include a decreased incidence of infections, such as necrotizing enterocolitis, otitis media, and respiratory tract infections, and that's due to the presence of immunoglobulins and probiotics in breast milk. Babies who are breastfed also have a decreased risk of sudden infant death syndrome, as well as a decreased risk of diabetes, asthma, and childhood cancers, and it is easier for babies to digest breast milk than formula. So it's recommended that exclusive breastfeeding take place for the first 6 months of life, and even after a baby starts taking solid foods, breastfeeding should continue throughout the first year of life. And Healthy People 2020 set goals for 80% of moms discharged to breastfeed their babies and 60% to breastfeed for at least the first 6 months. There are not many contraindications to breastfeeding, but a few for the mother are HIV, herpes simplex virus lesion on the breast specifically, exposure to radioactive materials, antimetabolites, or chemotherapy, active tuberculosis infection, and human T-cell lymphocytic virus infection. And contraindications for the baby include galactosemia. So how do medications transfer into breast milk? Most medications will enter from passive diffusion, and they leave the mother's blood and enter into breast milk. So medications that are not in systemic circulation for any reason cannot pass into breast milk. And this includes medications that have low bioavailability or that have large volumes of distribution and that do not remain in the blood compartment. Additionally, drugs that have a smaller size are more likely to pass into breast milk, whereas larger molecules such as proteins, including insulin, will not pass into breast milk. If there's a greater concentration of the drug in the blood, then it's more likely to diffuse into milk. And so one strategy to enable a mother to continue taking a medication while breastfeeding is to time its administration so that she's not pumping or breastfeeding during peak concentration for that drug to reduce exposure to the infant. And pKa can also affect drug transfer, as medications with a pKa higher than 7.2 can become sequestered in milk due to a phenomenon called ion trapping. Some other considerations when deciding whether a mother should breastfeed while on certain medications are, is that medication necessary? And are there any alternative options that can be used in breastfeeding that are safer or that do not pass into breast milk as readily? Should also consider the clinical status of the infant. Premature babies are at more of a risk for medication, adverse events, and exposure than term infants or older children who are more likely to not be exclusively breastfed by that point. Should also consider the possibility of drug interactions from the medication in the milk to any other medications the baby is on. And it's also important to note that for most medications, the benefit of breastfeeding far outweighs the risk of medication exposure. So while smoking cessation is always encouraged, smoking is actually compatible with breastfeeding. Nicotine does enter breast milk, but again, the benefits outweigh the risk, and that is including for nicotine replacement therapy as well. For alcohol, the American Academy of Pediatrics recommends that breastfeeding women avoid alcohol when possible, but small amounts are still compatible with breastfeeding. However, the mother should avoid breastfeeding for 2 hours following any alcohol administration. Breastfeeding is contraindicated in mothers who are using illicit substances, but if they're on recovery with methadone or buprenorphine, then they can still breastfeed their child. So for ways to increase milk production for women who are having trouble lactating, they should first try non-farm methods to increase milk production, such as adequate hydration, kangaroo care, self-breast massage, relaxation techniques, and lactation consultation. There are also pharmacologic methods to help stimulate milk production, and those substances are sometimes called galactagogues. One example is metoclopramide or Reglan, which works by elevating prolactin. It's important to note that at the end of therapy, the dose has to be weaned in order to prevent a decline in milk production upon stopping the drug. And it does have a black box warning for tardive dyskinesia, which is a concern for the mother, but there's minimal risk to the infant. Another galactagogue is domperidone, which is not available in the United States, but it's widely used in countries such as Canada and Europe. And like Reglan, it works by increasing prolactin levels. However, it does not cross the blood-brain barrier or cause tardive dyskinesia, so it is thought to be a little safer for the mother. Again, there are not many side effects that have been reported to the infant, and like Reglan, it should be weaned instead of stopped abruptly. Fenugreek is an herbal supplement that is also galactagogue, and it works by increasing sweat production. Clinical studies have failed to show any efficacy of this medication, but it's still commonly used to try to increase milk production. Side effects to the mother include maple syrup scented urine and sweat, diarrhea, low blood sugar, and difficulty breathing. Side effects to the infant are rare. However, it's important to note that fenugreek affects the INR, so it should not be used in women who are on warfarin. Some references that you could look into for any questions about lactation include the package insert. As of June of 2015, the FDA has required manufacturers to include lactation information in the package insert, such as the concentration of the drug that would be expected to be found in milk, side effects to the infant, and recommendations to minimize exposure. Other lactation references include Thomas Hale's Medications in Mother's Milk, LactMed, which is run by the NIH, and it's a website that's free of charge, and then Drugs in Pregnancy and Lactation. And it's always recommended to check more than one reference to verify the consistency of information due to the fact that there can be significant variation between resources. So now we'll talk a little bit about the hospital-specific TPN nutritional policies. So for nutritional requirements, a preterm infant needs about 120 kcal per kilo per day, and a term infant needs 90 kcal per kilo. And as far as fluids, the initial requirements are 80 to 100 mils per kilo per day, with a goal for preterm infants of 130 to 180. And fluids should go up daily by about 10 to 20 milliliters per kilo per day. However, infants who have patent ductus arteriosus may not need as much fluids as a normal neonate, but they should not receive extreme fluid restriction. The components of a TPN include amino acids, which provide protein, dextrose, which provide carbohydrates, lipids, which provide fat, and then electrolytes, multivitamins, and trace elements as other additives. So the amino acids in a TPN provide essential amino acids that the body cannot make on its own, and also helps to promote an early return to the birth weight for the neonate. Primusol is Huntsville Hospital's amino acid formulation of choice. And dosing goals for amino acids, the maximum should be 2.5 grams per kilo per day if that neonate is on Indocin, being cooled, or has renal failure. Otherwise, the goal is 3.5 grams if they're a term baby, or 4 grams if they're preterm. For dextrose, the maximum concentration of dextrose in a peripheral line is 12.5%, and in a central line it's 25%. Dextrose is an important component of the TPN because it's the brain's primary energy source, and neonates need it for their developing brains. However, preterm infants are at a higher risk of having hyperglycemia, and that has been associated with longer hospital stays, brain bleeding, neck, and late onset sepsis. But giving dextrose with amino acids can help increase insulin production and stabilize blood glucose levels. So the glucose infusion rate, or GIR, is a quantification of how much glucose a neonate is receiving from all sources. So if that neonate is getting glucose outside of a TPN, then the GIR needs to be calculated for each individual fluid and then added together for the total value. A minimum GIR that a neonate should receive is 4, and the maximum is about 12 to 15. The GIR of the TPN should be adjusted according to their blood glucose levels in order to prevent both hypo and hyperglycemia. And GIR is affected by both changes in dextrose concentration and rate of the TPN or fluid. So the lipid component of the TPN, Huntsville Hospital mainly uses SMOF in the NICU, and lipids are required to prevent the development of essential fatty acid deficiency, as well as poor growth, skin lesions, and visual and neurologic abnormalities. The starting dose of SMOF is 2 grams per kilo per day, up to a goal dose of 3 grams per kilo. And SMOF is run separately from the TPN, but both of them are hung at 1700, and the lipids will run for 24 hours and be changed out every 12 hours. So other lipid formulations, as I said, SMOF is the standard lipid of choice in the NICU, and it's composed of several different types of oil, including soybean oil, medium-chain triglycerides, olive oil, and fish oil. It's hung at 1700, then again at 0500 for a second dose, but SMOF can be run over 18 hours instead of 24 hours if the direct bilirubin is greater than 2. And that will require 2 separate orders, one to infuse for 12 hours and one to infuse for 6 hours. The other lipid formulation we use in the NICU is Omegavin, which is from fish oil triglycerides, and that's beneficial in neonates who have peripheral nutrition-associated liver disease or cholestasis. However, Omegavin is formulary restricted to pediatric patients who have a direct bili 2 or higher, and who are expected to be on parenteral nutrition for at least 2 weeks. And the dose of Omegavin is 1 gram per kilo per day. Omegavin is hung at 1700 for only 1 dose, and it just runs over 12 hours. We know that Omegavin is compatible with TPN, but there's limited data about compatibility for other medications. Monitoring for lipids. So lipids can be irritating to the liver and cause liver disease as well as cholestasis. Therefore, triglyceride levels should be monitored to assist in determining whether you can advance lipids to goal or whether you need to decrease or hold them. If their triglycerides are less than 150, then that's appropriate, and you can advance lipids to goal if they're not already there or maintain them at their goal level. If triglycerides are greater than 150, you may need to decrease or temporarily hold lipids depending on the magnitude of the elevation. Another monitoring parameter for lipids includes direct bilirubin, and so as I said, if that's greater than 2, then you can run SMOF over 18 hours. You also need to restrict it to 2 grams per kilo per day. You can add ursodiol or Actigol if they're on at least 60 mils per kilo for feeds, and you can also change SMOF to Omegavin if the patient meets the additional criteria of use for that. So for electrolytes, in a stock TPN it will contain 1 milliequivalent per kilo of calcium, and sodium and potassium are generally not necessary in a stock TPN on admission. However, in subsequent TPNs, you will add or remove electrolytes as needed to maintain stable labs, noting that you should use acetate sparingly, and potassium phosphate should be avoided whenever possible due to its high aluminum content. For babies who weigh more than 1250 grams, general starting electrolytes are 2 milliequivalents per kilo of sodium chloride, 1 of sodium phosphate, 2 of potassium chloride, 1 of calcium, and 0.25 for magnesium. Acetate is available either with sodium or potassium, and the liver will convert it to bicarbonate so it can help correct metabolic acidosis, but not respiratory acidosis. For acetate, you should monitor base excess and bicarb levels to assist in adjusting the levels in TPN. For multivitamins and trace elements, those are both dosed based on weight. The trace elements that we use are multi-trace neo. It comes as 0.4 milliliters per kilogram and contains zinc, copper, manganese, chromium, and selenium. If the patient has a direct bilirubin greater than 2, then the dose of trace elements needs to be halved because of decreased hepatic elimination. And another additive that can be included in a TPN is carnitine, which will be considered if the patient has been NPO for about a week, or if there's a plan for them to be NPO for an extended period of time, as carnitine helps aid the body in metabolizing fat for energy. So to write a TPN, TPNs are ordered at a specific rate, and it's acceptable to run the TPN at a rate lower than it was written for, but they should not be run at a higher rate due to the risk of receiving too many of the components and exceeding maximum allowances. If a rate is ordered higher than the TPN was written for, then should instead request to use piggyback IB fluids or increase the UVC fluids until a new TPN can be ordered. Central TPNs will contain heparin, but peripheral TPNs will not. And it is acceptable to move a TPN from a central to a peripheral line, but not from a peripheral line to a central line. So for new admissions that weigh less than 1,000 grams, the practitioner will start the patient on a stock TPN. And if it's prior to 1,400 that same day, then the pharmacist can start the baby on a customized TPN. And that will begin at 2.5 grams per kilo of protein, 10% dextrose, and then lipids at 2 grams per kilo. Electrolytes will be based on the baby's lab, but generally should include 1 milliequivalent per kilo of calcium and 1 of sodium phosphate, and then multivitamins and trace elements based on weight. For a new admission that weighs more than 1,000 grams, the practitioner will write the TPN to start at a certain rate, and the pharmacist will begin it that same day, starting with 3 grams per kilo of protein, dextrose in the same concentration as their IV fluids, which is generally D10. Lipids will still start at 2 grams per kilo, and then electrolytes as required, as well as multivitamins or trace elements based on weight. To adjust a TPN, you want to advance their protein up to a goal of 3.5 grams per kilo for term babies or 4 grams per kilo for preterm babies. However, you should not advance protein above 2.5 grams per kilo if they're on indomethacin, being cooled, or have renal failure. Should advance dextrose based on glucoses and GIR to make sure they're not hypo or hyperglycemic. Advance lipids to a goal of 3 grams per kilo if it's appropriate based on their triglycerides and direct bilirubin, and then adjust electrolytes based on their lab values. Finally, you'll want to continue the TPN at the initial rate that was ordered, unless a rate change has been indicated. If the rate has been written to increase, then a new TPN needs to be ordered, but if there's a rate decrease, then that same TPN can continue running with the adjusted rate. And finally, as a baby's weaned off of TPN and up on their feeds, we still need to ensure that they have an adequate amount of protein, fat, and electrolytes.